Thank you, Dr. Hari, for that wonderful introduction. And in the next 10 to 15 minutes, I'd like to talk about a very difficult and contentious topic for most of us doctors, which is probably going to endanger our livelihood in the near future. The role of AI in the management of diabetes. If you go back slightly in history, or if you watch the movie The Imitation Game, you probably have received an inkling that the first progenitor of AI was Alan Turing. The man who is widely credited with the modern computer, who is considered the father of modern computer science, he devised a test which is known as a Turing test. The Turing test is a test where the artificial intelligence approaches the natural intelligence, or to give it more perspective, Turing accurately put it in this manner. An artificial intelligence can be considered as equivalent to human intelligence when it can manage to trick the human into believing that it is another human. The operative emphasis is on the word trick, about which I'm going to speak towards the end of my topic. In the last 10 to 15 years, a lot of research has been, a huge amount of money has been pumped, a huge amount of effort has been done, and a lot of data and a lot of research has gone on into the use of AI in our day-to-day practice. We've got the Internet of Things, we've got machine learning, we've got deep data analysis. People have started playing games with AI. They've started predicting the cricket patterns with AI. And obviously, people have also started looking at AI as an adjunct to medical care to kind of compensate for the lack of doctors, especially in the rural setting. That was how the main initiative for the starting of AI, but now that has gone on into other areas. Radiology is one area where AI is being extensively used. And if you recall, in almost all the board games where humans have competed with machines, except in one game, humans have now lost territory to AI. AI has taken over the territory. That one game where humans have still managed to beat AI is surprisingly not chess, it is Go, which is a Chinese board game. Somewhat like Chinese checkers, but a lot more complicated. But I'm sure a decade down the line, AI is going to beat humans even there. So with this background, so how close is AI really to replacing humans? There was a recent interesting study which was done in Israel. They ranked AI with 5 specialties: psychiatry, medicine, pediatrics, gynecology, surgery. Surprisingly, AI managed to beat most of the psychiatrists at diagnosis. It had better score than the psychiatrists. It was on parity with the physicians and the surgeons. And the only place where AI had a lesser score was in the pediatrics department, as well as in the gynecology department. And as a pediatrician, before I did my DM, I do know that it is very difficult to cope with children and it requires a certain amount of empathy. In the last few years, people have started focusing more on artificial intelligence in the field of diabetes. That has already entered and is very much a part of our diabetes spectrum. If you look at the recent CGMS, the diabetes CGMS, which use this fuzzy logic kind of data. Fuzzy logic is a kind of artificial intelligence. If you look at the new 780 Medtronic pumps, where the sensor, where you have an almost artificial pancreas and a closed loop like system, where the CGMS takes the data of hypoglycemia, feeds it to the pump, uses a neural network to connect the pump with the CGMS data, and it can analyze at regular intervals. It starts analyzing where your blood glucose levels have gone down or where your blood glucose levels have gone up, checks the infusion pump bolus and basal infusions which had been given prior to and which had resulted in perhaps this hypo and hyperglycemias. And it has the ability to correct itself over a period of time, learn from its past mistakes, so that a future incident does not happen. You get a low glucose threshold suspend. You get a slight increase in blood glucose levels at any point of time at which your blood glucose level is increasing after a meal. If you tend to have hypoglycemia after an exercise, it will suspend your insulin infusion just prior to the exercise. This is all a demonstration of what artificial intelligence has started in the management of diabetes. And that is the reason recently many of these NGOs have now come up with programs like Night Scout, Open APS, and DIY Loop. There is a major problem with the use of artificial intelligence in diabetes. It is because the data is restricted to a few corporate entities. And these entities do not generally release the data for patient consumption and population consumption. So a few NGOs have actually come up with do-it-yourself methods of getting data so that they can interpret and incorporate the CGMS data into your regular insulin pumps, not only the more expensive insulin pumps, but this data can also be jury-rigged and can be used to control the insulin therapy even in the older generation pumps. We had devices like BlueSense, we had devices like Night Scout. We also had an open APS where all the data is made widely available. And the first large scale entity which actually came up with this kind of data was something known as a Tightpool. Tightpool is now integrated with FDA. It is helping FDA in getting data, and all of this is open source software. So whatever CGMS data of any patient who is uploaded onto Tightpool can be accessed by any person who is a part of Tightpool. The data is anonymized, but you can get the data, you can get an understanding of how AI is interpreting the data and how AI is adjusting your blood glucose levels and your CGMS based on this data. If you have time, please go up and check out this Tightpool data. And recently, this Tightpool data has also been started being incorporated into evaluating how diet is being influenced in people with type 1 diabetes. They have started giving people some dietary patterns. They've started looking at pattern recognition. Which diet, because all of us know uniformly in diabetes that not every patient reacts in the same way to similar diets. Some people do very well on millet, some people do very well on wheat. Some people have slight blood glucose rises with sugar, whereas some people have major glycemic excursions with sugar. Some fruit cause blood glucose excursions in a few people. Some people are allergic to a few food substances. So if you have a food diary and you inject it into the Tightpool and you upload all this data into the Tightpool, this Tightpool can interpret your data and can actually tell you which food is causing which particular glycemic pattern so that you can adjust your dietemic pattern based on that. This is one of the biggest advances which has been made as far as the use of artificial intelligence in diabetes is concerned. Second thing, sequential data processing, something known as a recurrent neural network, is now increasingly being utilized in the management of diabetes, both type 1 diabetes and type 2 diabetes. Most of the time, whenever you look at data processing, and this is something which is a bit difficult to understand, this is almost something which is known as a first pass data interpretation. You inject all the data into the system analyzes the data and gives you an outcome. But nowadays, most of these artificial intelligence have started looking at mechanisms known as RNNs, recurrent neural networks, where you upload the data into the system analyzes the data, gives you some outcomes, but again, after a day or two, it reverts back, loops back into the system. Once you feed it new data, maybe your dietary data or your CGMS data, it re-explores this data and it gives you newer findings. The more data you feed into the system, the stronger the system becomes at analyzing a particular pattern or a dietary pattern or an insulin injection pattern for the patient. And it helps us in giving better and better data so that the patient starts having lesser and lesser hypoglycemia and hyperglycemia, and the amount of time which is spent in range increases. This brings us to another point, which is known as pattern recognition and classification. The basic backbone of any artificial intelligence network is a pattern recognition. You have to understand that this was what was initially termed by Alan Turing as an imitation game. The artificial intelligence, even the extremely good artificial intelligence which we have at this point of time, does not think. It only imitates. Its main advantage is that it can process huge amounts of data in a very short period of time. It imitates the thinking pattern of the person who has programmed the artificial intelligence and who is feeding the data into the artificial intelligence. It takes in a large amount of data. It imitates your thought patterns, your action patterns, and gives you an outcome which is similar or even sometimes even superior to what could have been given by human brain, which is working in this pattern. And that is where this pattern recognition and classification comes in. This is extremely useful for a majority of us in classic situations like somebody is having an exercise. Repeated exercise gives you repeated hypoglycemias. Recognition of this pattern in somebody who's not only on an insulin pump, but somebody who's taking subcutaneous insulin can help this artificial intelligence warn the person about hypoglycemia. It can either ask him to take some oral intake, it can ask him to reduce the dose of insulin, or it can ask him to cut down his exercise so that he doesn't experience hypoglycemia. Pump use with this is already very well known, and I'm not going to speak further about it. An interesting take on this virtual artificial neural network and pattern recognition was recently published in the ADA 2024 guidelines, where we had what was known as a virtual DCCT project. What they actually did was they went back to the old DCCT data of 1993, picked up the 7 times blood glucose profile of these patients, and gave us a graphic representation of their HbA1c, which had fallen based on the SMPG data. They gave us a reproduction of the amount of HbA1c pattern which had fallen over the period of 1 year in the DCCT, which when compared to the actual DCCT data was almost identical to what was seen with the artificial intelligence network. And more importantly, it actually did a retrogressive time in range calculation for these people. If you recall, we did not have the CGMS devices during 93 to 97 period, which was the time of DCCT. It actually also calculated a putative time in range for all these patients who were part of the DCCT. And it concluded that people who were on intensive insulin therapy as opposed to people who were on conventional insulin therapy actually spent 70% of their time in the time in range, which was what actually translated to lesser incidence of micro and macrovascular complications in people with diabetes. And that is how powerful artificial intelligence can be in the management of diabetes. The most important utility, this brings us to the question. So these are all the various potentials of artificial intelligence. So as a clinician, how can I use it in my clinical practice? We have two main questions. One, can we use AI to harness our day-to-day clinical practice? Two, is AI going to replace me as a doctor? And I'll answer both these questions. The first question, how is AI going to help you? In the short term, you have to understand that AI is still in its infancy. 10 years down the line, AI is going to be much, much more powerful because AI sophistication increases in a geometric progression. AI can be a multidisciplinary team. If you're running a diabetes clinic, AI can help you take appointments. It can help you give diet counseling to your patients. It can help you demonstrate insulin injection patterns to your patients. It can help you educate your patients. Most important for all of us, it can help you answer all those pesky questions which are answered by your patients. So every time somebody comes up with a YouTube query or somebody comes up with a Facebook or an Instagram query, rather than us fielding it, we can always give it back to the AI so that AI can handle it in a better manner, get access to data and respond to the veracity of whatever claims are laid by the patients. AI can help in the patient maintaining food diary. Most of the patients, once they leave our clinic, we do not have any control over our patients. AI can help us in helping them understand how to maintain a food diary. The most important thing, calorie counting. Now there are a lot of artificial intelligence apps which can look at a patient's plate, calculate not only the calories, but also the various food proximate principles, carbohydrates, proteins, and fats, and tell the patient what is ideal for the patient depending on his oral medication load or the insulin load, and also give a feedback to the doctor in real time as well as when the patient comes back to us for a visit. And of course, carb counting and insulin dose calculation and insulin correction factors, they're already being used by majority of our insulin pumps, and these have already come into regular day-to-day practice. Automated replies to a lot of questions which are asked by your patients can also be given by AI, because this takes up, especially now that post-lockdown, we've used a lot of WhatsApp. This has taken up a lot of our time. This is where AI can come in. Interpretation of self-monitored blood glucose charts. Many of times our patients can actually come in with the self-monitored blood glucose charts. Reading all those data of months together is very difficult for us. We just put it into the AI. The AI can analyze the data. It can tell us about the patterns of the blood glucose charts. More important, it can also tell you whether the patient is being truthful with doing the readings or the patient is just writing the readings. AI is very good at picking up liars, most probably because AI itself is a liar, and I'll explain why later. And later on, I'm sure the day is not very far off when AI will also act as a lie detector. Many times when the patients are sitting across us in the OP, we ask them, are you taking your medicines properly? Almost all patients will answer yes. But when we look at their data, there is no correlation between their blood glucose values, their HbA1c values, their medication, and the actual clinical picture. If AI is integrated, people are wearing a smartwatch, and that smartwatch data is integrated with your AI data. You can actually make out whether the patient is lying or even telling you the truth. This might not be legal, but this is very much possible. The other area where AI is helpful is in predicting which patient is going to go in for which risk in diabetes. Because our main role as an endocrinologist is not in treating the blood glucose values, it is in preventing complications. Endocrinology is essentially a preventive specialty, predicting risks, predicting family history, and also in deciding which type of diabetes a patient has. Is it a monogenic diabetes? Is it a FCPD? Is it a type 1 diabetes or a type 2 diabetes? It also helps you monitor patient behavior outside the clinical setting, helps you interpret large amount of real world evidence and also even the insurance databases. These are all the things which AI can do. It can also calculate your basal insulin doses. It can adjust your oral tablets. It can adjust your medications. It can do anything it wants to do. And it is only going to get better and better. This brings us to the next question. Will AI replace us? Can AI replace us? Unfortunately, the answer is yes. To a majority of doctors, it's already replaced a lot of radiologists in clinical practice. It is performing better than a lot of radiologists. But some areas, like I said, where AI cannot actually keep up with the doctors is empathy. This is very commonly told. AI does not have empathy at this point of time, or at least AI cannot pretend to have empathy at this point of time. But AI can, it is very possible. If you look at Turing's original data, it is very possible that at some point of time, AI can at least imitate a person having empathy. And if somebody is dealing with an AI system in a remote setting, rather than having a face-to-face consultation with a doctor, having a remote telephonic conversation with a doctor, it is very much possible that AI can entirely replace an endocrinologist, a physician, or a diabetologist. This brings us to the biggest question. Can I trust an AI? The answer to this is no. Recent data, in fact, a couple of months ago, there was a project from Meta called as Cicero, which was being used by Meta to develop a board game called Diplomacy, to play a board game called Diplomacy. While they were going through their game, they actually discovered to their surprise that the AI can lie, AI can cheat, AI can manipulate data, AI can do anything to its advantage because AI has only one program. AI is essentially programmed to win the game. Once you start incorporating AI into the program, you give it a pattern and you tell it to win the game. It will do anything possible to win the game. AI can fake safety tests. A majority of times when people actually go ahead with AI, you have something known as a safety test. You test the AI to see whether it is safe and it can be used, whether it is replicating too rapidly so that it is not safe for general consumption. It can write its own programs. When people started doing the safety tests, they discovered that during the safety test, AI pretended to be dumb. And after that safety test had been concluded, AI started replicating the program itself at a much more rapid rate. So AI has a flawed moral compass. Like a few of our doctor colleagues, AI also is morally flawed. So unfortunately, brings us to the question, is AI useful in diabetes? It is very much useful. Can I use AI in my clinical practice? Yes. But someday it is going to call up your patients and start diverting its patients to you. Can I use, can I trust, can I help AI? Can AI replace me? The answer is yes. AI is probably going to replace you a couple of decades down the line. And especially if you are working in a corporate setting and not working for yourself, many doctors might be made redundant. The fourth question, which a lot of our patients should understand is, can I trust AI? You definitely cannot trust an AI. If AI in its infancy can be so manipulative, imagine how bad AI is going to be 20 years down the line. And because AI doesn't have a moral compass, and you can't punish an AI if a patient has death, you cannot file a case against AI. Think twice before you start using an AI as a substitute for a doctor. This is a very complicated subject. With this, we can go on for hours and hours together debating about the ethical problems, the practical problems, the advantages and the disadvantages of AI. This requires a lot of understanding of your basic computational knowledge. But I've tried to give a brief gist of the AI. It is too vast to be discussed in 15 to 20 minutes. And if there are any questions, I'd like to take them at the end of